Hey everybody, and welcome back to the second installment of this ventilator lecture I gave a while back. Right now we're going to answer the second row, which is why and when should we use these non-invasively. So that means the ventilators non-invasively. And to do that, we really have to understand the types of respiratory failure. And the two types of respiratory failure are type 1, hypoxemic. So if we just break that down, hypo, which is going to be low, oxemic, oxygen, it's an oxygenation problem. We're having trouble moving oxygen from one area to another. Type 2 is hypercapnic. Now that means a rise in CO2 or a retention of CO2, which is commonly a ventilation issue. We're unable to move that CO2 outward and be able to diffuse outward. So let's go to type 1, this type of respiratory failure, because what I want you to be able to do is walk onto a scene or have a patient come into your ER, or you on an IFT go somewhere and go into an ER and see this patient and be able to understand within seconds that this is a type 1 hypoxemic issue or this is a type 2 hypercapnic issue, or just be able to understand this is an oxygenation problem, this is a ventilation problem. So can you guys think of any modalities or any pathologies that can consider themselves an oxygenation issue or an oxygenation problem? Why don't you guys take a second, just take a beat and think about it. What are some processes that you guys have seen out in the field that cause an oxygenation issue? Well, if you thought about or answered any of these, you're right. Pneumonia, pulmonary edema, pulmonary hemorrhage, which is kind of the same thing, or any respiratory distress that causes a VQ mismatch. Now that sounds really fancy, but all VQ mismatch means is ventilation perfusion mismatch. That's it. Now, there's some other things that actually come into play with some of these, and these are some vital signs that are pretty important. Now, I put on here SaCO2, or SaO2. Now, that's saturation of arterial oxygen, less than 90. But in the field, and most of the times in the hospital, unless we have proper equipment, we don't really measure SaO2. We measure SpO2, right? So we measure the end of our fingertips, the hemoglobin at the very end, connected to our red blood cells, and the amount of oxygen attached to those. But if we have a 90% SpO2, we can say that we have at least a 90% SaO2. So it's sort of going from the very, very bottom up. So if we have an SpO2 of at least 90, so you could replace that with an SaO2 with SpO2, but I want to try to get you guys to understand that differentiation between the two. So if you have an SpO2 of at least 90 and an FiO2 of greater than 0.6, so that means you are delivering 60% of oxygen or greater, and you still have less than 90% SpO2, that's commonly an oxygenation issue. It could altogether be both, but these are some critical things that you can look at. So say you got them at an NRB, they're really having trouble breathing, and their SpO2 is still in the crapper. It's more than not an oxygenation issue. It could be pulmonary edema. It could be pulmonary hemorrhage. It could be exacerbation of pneumonia. But it's something that I really want you guys to be able to hone in on, because if you're able to state it's a type 1 problem, then you're able to go further from that. Okay, it's a type 1 problem. It's a pneumonia issue. And here's what I'm going to do for pneumonia. It's a type 1 problem. It's pulmonary edema. Here's what I'm going to do for pulmonary edema. So let's look at the other one, type 2. So this one, it's pretty different, right? It's a ventilation issue. It's not being able to get rid of CO2. Now, can you guys think of any modalities that you guys have seen in the field, that you guys have come across in the hospital, that you guys have picked up from another hospital that is a ventilation issue? Well, if you guys have answered any of these, some myopathies, asthma, COPD, and restrictive lung disease, you guys are on the right path. Now, here's another one that I want to throw at you. What about a patient who is a narco overdose? He took about, 20 mg oxy, and he is down and out, not respirating. That's a ventilation issue. He's becoming hypercapnic. He's retaining CO2. Excuse me, he's retaining CO2. Now, here's a good question that not many people think of. Why is asthma a ventilation issue? Shouldn't asthma be in the oxygenation issue one? Well, not really. Asthma is constriction of the bronchioles, those smooth muscle that just sort of clamp down and not allow you to exhale. They allow you to inhale just fine. They don't allow you to exhale. So that's why it's a ventilation issue. They are breathing just fine they're taking a good inhale, but they can't exhale very well. Thus, they become hypercapnic. Now, are you going to treat an asthmatic and a pneumonia with the same medications? Most of the time, roughly, yes. There are some medication differences, but they both are going to get albuterol. Now, COPD, that covers a wide range of things, right? And one of them is emphysema. If we think of emphysema, we think of those expanded alveoli that aren't able to really move that well, that probably have low surfactant, that probably can't exchange oxygen at that alveolar level that well. Does that mean it's solely a ventilation issue? No, it can be both. It can be an oxygenation and a ventilation issue, which is why COPD can be on either side, but most of the time it's a ventilation issue. Now, on the last one, remember, we had some vital signs that I want you to look at. On this one, we have some too. There are PaCO2, that's the partial pressure of CO2 within inside the arterial set, and a pH of 7.3, both of which we can't see, right? But here's the deal. If our PCO2 is greater than 50, that means our EtCO2 has to be at least 50. And it's the same way around. If our EtCO2 is, let's say, 45 or let's say 50, that means our PCO2 has to be at least 50. Do you understand how that works? It has to be this delineating thing. I can't have an EtCO2 of 75 or of some crazy outrageous number and my PCO2 still be low. That really doesn't make sense. And for the pH, remember pH that we'll go over in some of my other lectures is parts hydrogen. So that's our acidity. So if it's less than 7.35 is the norm. On this, we're going a little acidotic. On less than 7.30, then it's a commonality of a hypercapnic issue. And you could actually pull a pH from ABGs or from lab values that the provider gets if you're doing an IFT. But these are all supposed to point you towards using your EtCO2 to look and see if they're not ventilating quite properly. And we'll actually do an entire video on EtCO2 waveform and how it should be utilized and how it should be looked at and how you can use it in the field, and you should be using it on every patient, regardless if they're tubed or not. So these are two things, type 1 and type 2 respiratory failures. What I want you guys to do is really practice it on your next calls, on your next patients. Look at them, they're in respiratory distress, and think to yourself, just by what they're complaining of, and look at their vital signs. Is this a type 1 or a type 2 respiratory failure? Are they an asthmatic who's been an asthmatic for a long time, unable to breathe, and their EtCO2 is through the roof? Is it a 90-year-old grandma who has chronic pneumonia, whose SpO2 is through the floor, and you're trying to crank them on oxygen, get them on medications? You're going to see that it is a type 1 oxygenation issue. And these are going to come into play later when we discuss how to use the ventilator non-invasively and invasively on these two separate respiratory failures. Thanks so much for watching, guys. And on the next video, we're going to look how to use these non-invasively. All right, guys, I'll see you on the next one.